So welcome everyone. This is the first webinar that ECL, the Association of European Cancer Leagues, is hosting along with this time with IARC, the International Agency for Research on Cancer. So today we have members of ECL Secretariat, as for David Beridze, Officer on Cancer Control, and me, a research intern. We also have Joachim Schüz, our main speaker from the Environment and Vegetation Department from IARC, and as well Mariami, who's from Georgia already right now, one of our youth ambassadors. So just to introduce a bit what is that we do mainly on cancer prevention within the European Association of Cancer Leagues. We are gonna quickly share 1-minute video on the European Code Against Cancer, which is gonna serve as an introduction to the purpose today. So if you will allow me, I will share bit. Okay. So that serves as a little introduction, and then I'm gonna give the floor to Mariami Beridze, who's gonna introduce a bit a big part on the work we do for the promotion of the European Code Against Cancer with our Youth Ambassadors program.
Okay. Hello, everyone. As Mary mentioned, I'm Youth Ambassador from Georgia since 2015. The European Code Against Cancer is an initiative of European Commission, which is developed by WHO with the help of IARC, International Agency for Research on Cancer. The main aim of European Code Against Cancer is to inform people about actions they can take to reduce the cancer risk. About the Youth Ambassador program, it's founded in 2011 with the European Partnership Action Against Cancer. And now, currently, we have 42 ambassadors from different countries, from 34 different countries across Europe. And the main aim of for ECL and of the Youth Ambassador is to together gain and the highly motivated people from different countries and to promote the code in our countries and help the code to disseminate. And Dr. Joachim will talk about today's webinar. It's about health and environment, and the main topics are 3: radiation, occupation, and pollution. And this is shortly about the webinar and about the ECL and Youth Ambassadors. If you have any questions, you can ask in the chat here, and you can raise your hands as well. Mary?
Perfect. Thanks a lot, Mariami. Yeah, so as Mariami was saying, you can ask any questions at any point. We're going to open the floor for questions at the end of the session, which is going to last maximum half an hour. And then at the end, we're going to have a little poll. So you'll be asked 10 questions, and then we will be able to see the results of the questions. Just to see how is it gone, what concepts have been clear, what concepts you would need a bit of more reading, and just to make it a bit interactive. So I'm going to proceed to introduce Dr. Joachim Schüz, who is the head of section of the Environment and Radiation at the International Agency for Research on Cancer, IARC, a WHO specialized cancer research agency. Before arriving at IARC in 2010, he was head of the Department of Biostatistics and Epidemiology at the Danish Cancer Society Research Center in Copenhagen. Before moving to Denmark, he worked at the Johannes Gutenberg University of Mainz from 1993 to 2005, starting as a research fellow and finally as an associate professor of epidemiology. And in Mainz, he also completed his PhD in epidemiology in 1997 and his professorial qualification in 2002. Dr. Schüz worked mainly in cancer epidemiology, especially radiation epidemiology, epidemiology of childhood cancer, and on statistical methods in epidemiology. Therefore, he is our biggest expert when it gets to the messages 8 and 9 in the Code Against Cancer, mostly related to environmental health and effects in cancer. So I would like to give the floor to Dr. Joachim Schüz.
Okay, so thank you very much for the very kind introduction and welcome everyone. And so this is not only an opportunity to explain in a little bit more detail of how we have kind of considered environmental and radiation issues in the European Code Against Cancer, but really for me also an opportunity to endorsing the long-term excellent relationship and collaboration we have with the European Cancer League, and thanking for your strong endorsement of the public health recommendations that we have put in the code. So if you go to the first slide, please, this is really just a reminder of the topics of the code, which you hopefully all know. Before really going into the topic, I want to remind you of how we really developed this code and what were the 3 criteria that something that we know prevents cancer really became a recommendation in the code. So first of all, it is only a recommendation where we have convincing scientific evidence that the implementation of the preventive measure really works. So it is not related to precautionary measures. It is really messages that if people follow the recommendation in the code, then they would reduce the risk of cancer by a certain percentage. So you really see all established causes of cancer here, from tobacco, lack of physical activity, we know is a risk factor for cancer. You should maintain a healthy body weight. And so this is all topics where we have the scientific evidence that following the recommendation reduces your risk of cancer. At the same time, the 4th edition of the European Code Against Cancer includes recommendation where people themselves can make the difference. And here this is a quite important distinction. But it also only relates to exposures where you can yourself make a difference. For instance, of course, stopping tobacco smoking, which would be the best preventive measure if you're a smoker, and reduces your risk of cancer by the greatest extent. If you go on the website of the European Code Against Cancer that you also see here, then we say very explicitly that actually this concept of public health recommendations directed to the individuals has to be accompanied by also strong policies. We know, for instance, in the tobacco, the tax and price policies also have a huge impact on tobacco cessation. And when we talk about environmental exposures, then the policy making and the legislation become even more important because as an individual, you can contribute, of course, to less air pollution by, for instance, using public transportation or your bicycle when you go to work, but you don't have this direct effect that reduces directly your individual cancer risk. And the third criterion is that we could put these recommendations in a type of slogan that the individual can really follow it. So we wanted to avoid recommendations where the individual has to make a benefit and risk analysis because some of the exposures, some of the factors that we know cause cancer, for instance, also have a benefit. And I will give one example later, and this is the medical radiation. Of course, we know an X-ray examination is related to radiation exposure, but at the same time, of course, the image can be life-saving. And we wanted to keep out recommendations from the code where the individual has to make this risk-benefit analysis for themselves. So these are all clear-cut recommendations that you can follow to reduce your cancer risk. And if you go to the next slide, this is just really pointing out which are the recommendations related to the environment and to radiation. It is 3. It is the sun and UV exposure, exposure to ultraviolet radiation. It is the occupational chemicals, and it is the radon. And I will talk specifically about the 2 latter ones today. So if you go to the next slide, this is just a reminder of how the 2 recommendations really look like. So recommendation number 8 in the code says, in the workplace, protect yourself against cancer-causing substances by following health and safety instructions. And number 9, and this is really in addition to previous versions of the code, find out if you're exposed to radiation from naturally high radon levels in your home, take action to reduce high radon levels. And this was really a recommendation that we discussed in the expert group for a long time, not because there are any doubts that high radon levels can cause cancer, especially lung cancer. It was the question, is it the individual that you really can do something about it? And we know that it's not all European countries that have published maps of which are the areas of high natural radon in your country to make a first assessment of whether your house is potentially in a high radon area. But most European countries are on the way to producing this kind of maps. And in the meantime, we also know which would be good measures to reduce high radon levels in your house should they really occur. And this is some renovation measures and increased ventilation, how you can decrease the radon levels. So in my talk, I will first start now with some more general remarks on cancer prevention, and then go into these topics of radiation, occupation, and pollution in a little bit more detail. So next slide, please. So why do we need cancer prevention? This is really the cancer burden in the 28 EU countries. And the light blue bar shows the cancer incidence, meaning the new cases of cancer in 2018, and the cancer mortality, meaning how many deaths we have in the European Union in 2018. And you can see that we have each year about 3 million new cases of cancer at the moment, and about 1.5 million people die of cancer in the European Union. So if there's no change in the underlying incidence, meaning that cancer prevention would stay as it is at the moment, then these numbers would really increase over time. And this is due to the aging of the European population. With a higher life expectancy, we have more people who are reaching the cancer-prone ages, and thereby the incidence would increase to more than 3.5 million in the next 20 years, and the cancer mortality almost reach 2 million in the next 20 years. And if you press another time on the slide, then you see that this actually corresponds to an increase of the incidence in 25% and more than a third increase in cancer mortality. And this is not a major cause of death in the European population, but we can also see that it's a strong economic burden, and you can really not treat your way out of cancer. You have to enforce cancer prevention to really reverse this trend and at least stabilize, if not lower, the cancer burden in the European Union. So what do we know about this cancer burden? And this is the next slide. With prevention, we can, in the best case, avoid cancer. So this is the primary prevention by avoiding exposures to carcinogens, by changing our behavior when we know that this is a behavior that increases your risk of cancer, like a heavy body weight. We can do with vaccination, medical prevention, also reduce the burden of cancer, especially, for instance, the new vaccination programs against human papilloma viruses are extremely successful in eradicating cervical cancer. With a secondary prevention, we can detect cancer early, which is mainly, of course, a measure to reduce the cancer mortality, but we can also, for some cancers, detect them at such an early stage that it's not becoming a really invasive cancer. So for instance, again, with the cervical cancer, we can detect it at stages before it becomes cancer and treat it successfully. And then there's also the tertiary prevention, and this is mainly having an effect of the cause of disease by medical prevention or behavioral change, really try to reduce the risk of metastasizing of the cancer or recurrences of the cancer. And with the European Code, we mainly address the primary and secondary prevention. And on the next slide, you see actually, when we are talking about cancer, of course, we all know that there's very different types of cancer, that the preventive potential is very different if you look at the different cancer subtypes. So in the, that's a very busy slide, but on the left-hand side, you see actually the cancers for which we know a lot about the etiology, what causes the cancer. So the prevention potential for these cancers in the left column is more than 75%. So this is cervical cancer, we have lung cancer here, oral cavity cancer. For these two, it's mainly the smoking, esophageal cancer, melanoma of the skin, and stomach cancer. These are all cancers that we could prevent quite successfully if we implement everything what we know about the prevention of these cancers. Colorectal cancer, bladder cancer, kidney cancer, liver cancer, uterus cancer, pancreatic cancer, and breast cancer. These are among the cancers where we can prevent around 50%. So we've identified about 50% of the causes, and we could reduce the burden quite substantially. But then we shouldn't forget that there's also cancers where we don't know a lot about the etiology. Ovarian cancer, the system cancers, leukemia and lymphoma belong to this group. Prostate cancer and brain cancer, we know virtually nothing about their causation. So in addition to the prevention, we also have to continue with the research because there's still a lot to detect in the etiology of cancers. So this is the kind of perspective from the cancer side. If you look at the different risk factors, and that would be on the next slide, it has really been two very recent estimations from the United Kingdom and from France of what are the different contributors to the cancer burden. And so for France, it was estimated that we know the causes of around 50% of the cancers occurring in France. It's a little bit less in the UK. And you see the major player in this slide. This is still on the left side in the dark blue, the tobacco. So almost half of the preventable cancers in Europe is still with tobacco. And then you see significant portions also with alcohol consumption, unhealthy diet, overweight, infections around 5%. And then comes occupation, UV and ionizing radiation, the three environmental causes, before we have physical activity, hormones, short breastfeeding as a risk factor for breast cancer, and the pollution as at the moment minor contributors, and about 50% of causes of cancer unknown. So if I summarize for the environmental exposures, please for the next slide, we estimate that occupational exposures contribute to the cancer burden with around 3 to 4%. Ionizing radiation is about 2%. Half of this is attributable to radon exposure, and the other half is more or less attributable to medical exposures, meaning X-ray examinations, especially CT, computed tomography examinations that have a high dose of radiation. And at the moment, air pollution contributes with less than 1% to the cancer burden in Europe. But this number really has to be seen with a caveat, and this is what I like to illustrate on the next slide. Because this is some data on mesothelioma, and mesothelioma is a pleural cancer that is virtually exclusively caused by exposure to asbestos. So here we have an environmental cause of cancer, and we see the effect it has on the mortality. So what you see on the left-hand side is the cancer mortality of mesothelioma in East Germany, and you see West Germany on the right side, and the dashed line with the little dots is the one that I like to focus on, because this is the mortality for all ages combined, and this is the number of deaths. And what you see is an increasing trend still in the mortality that will only be reversed in the year 2020. From when on we expect declining rates. But the interesting thing is that asbestos has been completely banned in Germany in the early 1990s. So we see even an action against an environmental carcinogen and still increasing rates in the mortality of a cancer that is exclusively caused by this environmental carcinogen, and only 30 years later you really get a reversal of this trend. So when we talk about the air pollution and the 1%, then this is the effect of the air pollution that we had 10, 20, 30 years ago. So we have to be proactive now to at least stop an increase in air pollution. Otherwise, there might be a cancer epidemic that we only see in 20 and 30 years. And hopefully, our politicians and decision makers have an understanding to not always wait until the epidemic occurs, that you try to reverse the trend, because then it takes 20, 30 years until this happens. But be proactive and be also active against things that we know cause cancer, even when the contribution at the moment is not so big. Okay, next slide. I'm going now into the various environmental exposures, and the first one is radiation. So we know that radiation causes cancer for quite a long time. One of the discoverers of radiation, Marie Curie, actually died of the consequences from radiation exposure herself. And of course, most of the data that we have collected on how big the cancer risk is, that there's some age sensitivity and which cancers are affected. This is what we know from studying the populations of the atomic bomb survivors in Hiroshima and Nagasaki. But of course, these people were also exposed to very high doses of radiation, so that there's still some scientific uncertainty of what the radiation effects would be at low doses. And of course, many more people in the population are exposed to low doses of radiation than high doses of radiation. So this is very important for the prevention. At the moment, a model that is really, I think, favored by the science is the so-called linear no threshold model, which means that any dose of radiation, how small it is already increasing your risk of cancer. Very small in magnitude, but nevertheless, you would not have any safe level of radiation. The other model that was around for quite a while and being discussed among the scientists is a threshold model that would suggest that there is a safe level and that actually below a certain exposure, you would not see an effect. And then there's also people who believe in the hormetic model, and this means that low doses of radiation is even good for you because it's training your DNA repair system. But I must say, I'm not a great admirer of this hypothesis, and I think the scientific evidence is more and more accumulating that the linear no threshold model is the correct one. And this is what I illustrate on the next slide, because this is actually a very recent study that we have published from the International Agency of Research on Cancer, and this is the results from our nuclear worker study. So this is more than 300,000 workers in nuclear installations from the UK, from France, and from the United States, and following them up for their leukemia risk and also for the risk of solid cancers. And this is what you see on the left side of the slide. So this shows you really that there's an increasing risk with increasing dose and the radiation exposure estimated as the colon dose. What is shown in these very different colors is that some people argued you only see a dose-response relationship because this is influenced by the outliers with the very high doses. But even if we analyze only people that have doses up to 100 millisieverts, 200 millisieverts, or 150 millisievert, we still see this linear dose-response trend really arguing in favor that this is the correct model for ionizing radiation and cancer. And the same is true for the leukemia on the right side. And you see the excess relative risk also displayed on the slide. So the risk of leukemia is much higher than the risk for the solid cancers. So there's no doubt any type of radiation, any type of ionizing radiation is related to an increased risk of cancer, very small in magnitude at very low doses, but nevertheless increasing with increasing dose. Next slide, please. So if you look at the different sources, then medical radiation is one of the prominent sources. So this is recent results from studies looking at children that were undergoing a computed tomography examination and looking at their leukemia and brain cancer risk in the long run. And you see more or less the same picture that we saw in the nuclear workers, an increasing risk with increasing dose from CT examination. If you look at the similar results on the next slide related to radon exposure. So this is a pooling of 13 studies around the world that looked at domestic radon exposure and lung cancer risk. And again, the same picture with an increasing dose of exposure in your home, your lung cancer risk increases linearly with dose. And based on these results, WHO has actually recommended an action level for radon, that if in your house you have an accumulation of radon of more than 100 becquerel per cube meter, then action should be taken to reduce this radon level. So the next slide, I think, shows the different sources of radiation, and this is typical for Europe. It's data from Germany, but it's broadly representative, I think, for most of the EU countries. So the typical annual radiation dose of a European is around 2.4 millisievert. And you see from the chart diagram of what the different contributions are. So the biggest contribution is the medical radiation. And of course, this varies strongly between people. So if you didn't have any examination, X-ray, CT during the year, then of course you don't have the exposure to this 1.5 millisievert. But of course, if you have CT examinations, X-ray examinations, this can quickly go to values more than 10 millisievert. The others are more constant contributors. So radon is the next strong contributor with 1.3 millisievert on average, but of course with strong regional differences. Cosmic radiation is depending on the altitude where you're living. So ski holidays or frequent flyer gives you higher doses of cosmic radiation. Other natural sources, terrestrial sources mainly, is around 0.8 millisievert per year. And what people, of course, fear is the nuclear-related radiation, but this is a very small contributor to the overall dose. So these are really calculated doses where the different types of radiation are weighted already. So alpha transmitters, beta transmitters, gamma radiation. And when you calculate the organ dose of a subject, then you can actually compare across radiations. So there is no good or bad radiation. All the radiation is in fact the same. And of course, it's much more difficult to protect yourself against natural radiation, and against cosmic radiation, there's hardly anything we can do. Next slide, please. So this is a very interesting result from a survey that WHO did, because they were measuring really the public concern in a random sample of the population, what they think, how harmful different types of radiation is. And on the left side, you see the true public health effect from the different types of radiation. So UV is causing the strongest effect, followed by radon, medical radiation, as you have seen, much smaller by nuclear power. And for electromagnetic fields, the non-ionizing radiation, we have not yet established whether it's carcinogenic at all. But if you look at the public concern, when this survey was carried out, people were most concerned about the EMF, then followed by nuclear power, X-rays. People were not so concerned about UV. So you see there's a lot to do in risk communication when it comes to radiation, because the public perception is quite different compared to where the public health effects are. And on the next slide, this is really now quick information on the non-ionizing radiation. So there has been quite some debate about the extremely low frequency magnetic fields. So these are fields that are emitted, for instance, by power line or by any electrical device that we are using, and the risk of childhood leukemias, because there were some epidemiological studies that showed an increased risk of childhood leukemia in relation to elevated fields. But we have not established any mechanism yet. We have little support from experimental research, and there's concern about bias and error in the observational studies, so that there's consistency in all these groups that did hazard or risk assessments for these magnetic fields by IARC in 2001, by WHO in 2007, and by the European Commission Scientific Committee on Emerging and Newly Identified Health Risks last in 2015, saying that extremely low frequency fields are not established carcinogens. And the same applies to the radio frequency fields that were recently, on the next slide please, that were recently evaluated by the agencies. So we do have some results that suggest among very heavy users of mobile phones an increased risk of two types of brain tumors. One is glioma, one is a tumor of the vestibular nerve. So this is very close to the ear, where you actually also hold a mobile phone. But again, the evidence was not convincing to say it's carcinogens. It's possibly carcinogenic, which means we have to do more research. Perhaps if you really are a heavy user of a mobile phone, take some precautionary measures. But clearly EMF did not make it into the code because we cannot guarantee you that any protective measure will reduce your cancer risk. And this is also illustrated on the next slide, that if you look at the brain tumor incidence rates that are quite informative, because in the early 90s hardly anybody had used a mobile phone. Now I think probably 100% of the population are using a mobile phone. So if mobile phones were really related to an increased risk of cancer, we would see this in the incidence rate. And what you see on the left hand of this slide, this curve that is going up and down, this shows the brain tumor, the glioma incidence rate in the Nordic countries. And you see there's a little bit of variation, but there's no trend, increasing trend in the incidence rate. And the three colored other incidence rates, these show of how the incidence rate should look like if there was really a doubling in risk with mobile phone use, if there was a 50% increase risk with mobile phone use, or if there was a 20% increase. So if there's a risk related to mobile phone use, we know it would be very small. It would for certain not be another smoking. It would probably affect only very heavy users of mobile phones, if at all. So going to the next carcinogen, I think that is on the next slide. And this is really the occupational cancers. So I said already that occupational cancer is around 3 to 4%. This is the cancer burden. And in the UK, they made a more detailed analysis, really looking what are the occupational exposures that contribute to this cancer risk. And you can see that number one is the exposure to asbestos, causing not only mesothelioma, but also lung cancer. Mineral oils is another strong contributor. Then comes actually the UV radiation in outdoor workers, silica exposure, diesel exposure, and also passive smoking is one of the major contributors for people that are occupationally exposed. Next slide, please. If you look again, and you can press another time the button, if you look at what has been established in the occupational environment as potential causes of lung cancer, then you actually see a long list. So these are all factors that have been shown to increase your lung cancer risk, irrespective of the smoking in different occupational settings. And the asbestos is the major contributor, but then you see arsenic, you see chromium-6, you see workers in the rubber industry, in the coke production, you see cadmium, you see coal gasification, and of course you see the radiation, but also the painting. So there's a lot of factors, but due to the number of people that are exposed, these are all rare exposures, and thereby, and this is what you see on the next slide, even for lung cancer alone, the occupation contributes only 10 to 15% of the total lung cancer burden. And we have to keep in mind that active smoking is really the major contributor here with almost 90%. You see that these numbers actually add up to more than 100%. And this is because of the interactions between the different factors. So for instance, if you are exposed to asbestos and you are at the same time a smoker, then you have a multiplicative risk increase. So this means that if you only remove the asbestos, or if you only remove the smoking from a person that is smoking and exposed to asbestos, then of course you can reduce the cancer risk. And this is why they all add up to more than 100%. And you can see also for the lung cancer, the air pollution, at the moment the contribution is around 2 to 4%. Next slide, please. So this brings me to one of the most common environmental exposures, and it's also a hot topic at the moment, and this is the air pollution. And I mean, air pollution is like more a frame for very different individual exposures that are related to air pollution. So air pollution as such has been classified as a human carcinogen very recently in 2016 by the agency, and also the particulate matter in outdoor air pollution is now classified as a human carcinogen. There's sufficient evidence for lung cancer, and there's also positive associations with bladder cancer. Before this, in 2014, diesel engine exhaust has already been classified as a human carcinogen, again with sufficient evidence for lung cancer and positive associations also for bladder cancer. However, most of the data actually comes from occupational exposure settings. So how the magnitude of risk really looks like for those exposed in the environment, for instance, by living close to a very busy street in the city, it's more difficult to estimate. Indoor emissions from household combustion of coal has been classified already as human carcinogen, and also the household use of solid fuels. This is not one of the major contributors in Europe, but this, for instance, causes a huge lung cancer burden in countries like China or in many African countries where household heating, where the heating and the cooking in the household is still done with solid fuels. On the next slide, please, you see how big the risk with the different substances in air pollution really is. So this is a pooling of air pollution studies that were done to look at the risk of two different types of particulate matter. So it's 2.5 micrometer diameter and the 10 micrometer diameter. And you see on the left-hand side that the risk increases with around 10% per 10 microgram increase per cubic meter in the PM2.5, and it's quite similar for the PM10, what you see on the right-hand side, with 8%. So you see also a little bit of variation of in which continent the studies have been done. So for Europe, the risk was a little bit lower than what they estimated for North America or for Japan. But again, for the air pollution, like for the radiation before, the linear model seems to be the most appropriate one to estimate the cancer risk. Next slide, please. So what does this really mean for a country? And this is some recent estimations that we did for lung cancer in France. So if we apply the measurements of particulate matter that are done by the stationary measurement stations that you have in many cities now, and apply this to the lung cancer risk, then you can estimate how many lung cancers or cancers would be attributable to the exposure. And then you see actually, which is a little bit alarming, that in this sample, more than 80% of the French population were actually exposed to a higher value than 10 microgram per cubic meter in average. So you can see that air pollution is really a relevant topic. If you apply it to the recent trends of lung cancer, then you would estimate about 3.6% of lung cancers would today be caused by air pollution, which makes this 0.4% of all cancers. There's a lot of statistical uncertainty related. So if you play a little bit with the models, then the attributable fractions could actually be higher. 8% estimated if you take another reference level that actually causes an effect. So if you apply the no threshold model, and if you use different steeper risk functions like the ones measured in the North American countries, then it could be as high as 26%. Next slide, please. So finally, this brings me to the conclusions and summing up this talk. So for the radiation in the European Code Against Cancer, we give the recommendation to reduce high radon levels. We know that higher radon levels increase the risk of lung cancer, and we know that there are measures how you can actually reduce the radon levels in your home. For the medical radiation, we have no recommendation, but we address it in the questions and answer part, because there would also be harms if people refuse necessary X-ray examination. So we have to be careful in what we recommend. And for instance, we also recommend a mammography screening in the code itself. And of course, mammography is a radiation exposure, but the benefit you get from the screening is still higher than the additional risk that you get from these radiation examinations. So how we try to address the problem is rather increasing the awareness among the radiologists to always apply the lowest doses possible. For the occupational radiation, following the occupational safety measures is what is included in the code. And for electromagnetic fields, we have no recommendation because there's no guarantee that it would reduce your cancer risk. For the occupation and the environment, we do have the occupational safety recommendation in the European Code Against Cancer, and environmental exposures. They are mainly addressed in the question and answers because it is action that has to be done by the policy makers rather than by the individual, and therefore this needs more work on a decision maker level. But of course, the individual should be aware of these exposures that you have in your everyday life. So this is why we also address them in the question and answer. So finally, and this is now really the last slide, this is just showing you a little bit of who are the people responsible for all this. So here you see the different working groups of the European Code Against Cancer and the Scientific Committee, which is really the directors of different European cancer institutions or public health institutions who have approved all these recommendations and made sure that they're really all on scientific evidence base. And by this, I really like to thank you for your patience and your attention.
Thanks a lot, Joachim. So we proceed to open for questions the floor. So you can either click the button raise my hand, so then we'll just give you the ability to speak through Zoom, or you can also type a question and then I'll just read it out. So we have about 7 minutes for questions.
So far there is no questions. Yes.
Okay, we wait for another minute, and otherwise we proceed to the a little questionnaire, like a poll, and it's 10 very basic questions. You will just have 2 options, but it's going to be very useful to just recap a bit the most important points that we were discussing today, and also see how much we address. And then finally, David Beridze, our cancer control officer in ECL, he's going to give final remarks. So I see no questions.
Yeah, maybe we can start polling.
Yeah, so I'll proceed the poll. So Mariami will help us with this.
So it will be just estimation and how much detail you will concentrate. Okay.
Good. So all of our attendees should be seeing now the questions.
So I hope everyone can see the questions on your screen.
Yes.
Yeah.
So we are going to have about 3-4 minutes to quickly reply. And then when all of the answers are collected, I'll get a notification, and then we can proceed to see the results.
Yeah. Okay, the first question is how many types of prevention exist? So 1 or 3, you can just click each of them. And the second question is what percentage of malignant disease is estimated to attributable to occupational exposure? 3 or 4%, or 15 or 20? Dr. Joachim mentioned about this. You may concentrate on this answer. The third question is about radiation and cancer. Which is the highest contributor to radiation exposure in Europe, cosmic or medical? There was a chart about this in the presentation. The first question, IARC classified the radio frequency electromagnetic field as a group 2B, possible carcinogenic, or group BA, probably carcinogenic. Number 5, which cancer is highly attributed to occupation, mesothelioma or pancreatic cancer? Yeah, I think it's too easy to answer. Question 6, which factor has the highest percentage in causing occupation and lung cancer, outdoor air pollution or active smoking? It's maybe a tricky question, but the answer is, you know that. The question 7, in a household use of solid fuel, biomass classified as a probably carcinogenic or probably not carcinogenic to humans. Question 8, even the smallest dose of radiation is not safe, although the related risk is small. Is it true or false? Question 9, diesel engine exhaust is known to cause brain cancer or urinary bladder cancer. Okay, and the last question 10, indoor emission from household combustion of coal can cause lung cancer or prostate cancer. So all of the questions, so all the answers were in presentation. So it would be easy to answer the questions.
Good. So we have already about half of the answers collected.
Okay.
And we already have a question that just popped up. So we're going to address it after the poll.
Okay.
In the meantime, I'm going to take a little picture.
Okay.
Okay. Waiting on a couple more people. One more person. Let's see how it went. It's looking quite interesting. Okay, good. So we're going to share the results. Good. So Mariami, go ahead.
So the first question, yes, it's correct. There is three types of prevention. The second, what was so there's the correct answer is 3 and 4%. 15 and 20 is too high and too much. And question 3, radiation and cancer, which is the highest contribution to radiation exposed in Europe. It's medical. That's it. Medical is correct answer. And the question 4, it's possibly carcinogenic. That's correct. And question 5, which cancer is highly attributed to occupation? It's mesothelioma. Yes, that's a correct answer. Which factor has the highest percentage in causing occupation and lung cancer? This is active smoking. Yeah, 90% is correct. Household use of solid fuel classified as a probably carcinogenic. That's right. Everyone answered correctly. Even the smallest dose of radiation is not safe. Yes, that's true. And diesel engine exhaust is not. Yes, it's urinary bladder cancer, not brain cancer. So 50% correct answer. And the last question, it's about the lung cancer. Yes, indoor emission from household combustion of coal can cause lung cancer. I think the answers, yeah, it's quite interesting because some of them maybe it was too detailed for general population to know that, but I think this is interesting contribution.
Thanks a lot, Mariami. So I'm going to read a question for Dr. Schüz. So, is there any socioeconomic gradient in exposure to carcinogenic environmental exposures?
Sorry, can you read it again?
Yes. Is there a socioeconomic gradient in exposure to carcinogenic environmental exposures? That's a question.
Oh yes, 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 there is. So this is very clear that you have a lot of. I mean, most of the occupational exposures, for instance, we know occur much more often in what we call as the so-called blue-collar workers, for instance, rather than the white-collar workers, which would be the ones of the higher socioeconomic position. So you clearly see the difference in the occupational exposures. A lot of the very common carcinogenic exposures, like also the silica exposure, occurs in construction. It's very often manual workers. When you look at air pollution, then you also see a trend that it's not necessarily the most posh neighborhoods that have the highest levels of air pollution. But of course, here the difference between urban and rural is much higher than the difference across the socioeconomic factors. So we do see higher exposures in lower socioeconomic groups.
Thanks a lot. We have another question. So not specifically in radiation, but in terms of the code against cancer. So I read out, one of the goals in vaccination, including the HPV vaccine for girls. In the UK, as far as I know, they're planning to apply this vaccine to boys as well, since it causes penile cancer. Do you think this should have been in the code, not to exclude this small possibility of cancer?
So in the code, again, in the code, we have decided we want to give the recommendations what the individual can do. So for the policymakers, the agency has always endorsed that there should be also vaccination programs for boys, not only for the reduction of the risk in boys themselves, but also to keep this kind of lower HPV levels on an endemic level. I mean, if less men are infected, that also has, of course, consequences on the infection levels in women, because it's the sexual behavior that transmits the virus. So in the code, the reasons why we didn't put the program for boys as a recommendation for the individual was that at that time it was only one country who actually offered a program for boys. And if more countries are actually following this advice, it might be that in the next revision we also encourage the individual. But at the point when we had to make this decision, we didn't feel really that it should be the responsibility of the families, because you would have paid also out of the pocket for the vaccination for boys. But the more we succeed in getting programs on a national level, the more we can also recommend for boys to participate in the programs.
Excellent. All right. So if there are more questions, I will proceed to give the floor to David Beridze, just for some final remarks.
Thanks, Beridze, and thanks also to Mariami for hosting the webinar today. And of course, a big thanks to our friend Joachim at IARC for an excellent summary overview of the evidence on these important messages that are within the Code Against Cancer 8 and 9, but also more broader scope of these important issues of the carcinogenic environmental exposures. So this is really a fantastic, highly informative and instructive presentation. Draw people's attention to the conclusion slides, which reinforces the importance of what we call the second level of the European Code Against Cancer. So of course there are the 12 messages, which we've covered in some detail today, 8 and 9. But Joachim excellently highlights there that there's the question and answer section, and this is the second level, which is also extremely valuable resource, which we ask you all to pay attention to, and because there's a lot of information there, and we're hoping soon to be able to get the resources to be able to go further and update this important additional resource to the 12 messages against the Code Against Cancer. So thanks again for everyone who's been online, participated. This webinar has been recorded, so it will be available on our website and will be available for you to view again and refer to, be able to follow the slides and the information. And of course, if you have any information you would like to get from us or any questions following up from this, then our contact details are also available on the website. So thanks once again for everyone for being available here, and I hope you have a nice evening and weekend. Thank you.